Okay, and now for some light entertainment. I'm going to give you a talk. MVD for achalasia with a big question mark afterwards. All right, let me walk you through what I was thinking. So if you compress the motor component of vagus, you'll get a motor reaction in the larynx and pharynx. If you compress sensory component of the vagus, you'll get a sensory response in the distribution of the vagus. What happens if you compress the parasympathetic component? And I was thinking about this. Well, we know that if you compress the parasympathetic component of a cranial nerve, you lose parasympathetic innervation, right? You don't get a parasympathetic hemifacial spasm, you lose it, and we know this as neurosurgeons from the third nerve palsy. So I was thinking, if you have a sympathetic and parasympathetically innervated sphincter, and you lose parasympathetic, you get overactivity of the imbalance of the sympathetic, and you see that with the pupil. Is there a sphincter that has sympathetic and parasympathetic innervation of the vagus? Yes, there is. The lower esophageal sphincter. Sympathetic closes it, parasympathetic opens it as part of your peristalsis and gut reaction. So if you're going to lose parasympathetic, you would lose the opening of that sphincter and you would have more closure. You would have a lower esophageal sphincter that just wouldn't open normally. Right around the time I was thinking about it, the first case who had surgery for HELPS, and I used, I deflected the pica inferiorly with a lot of Teflon. She was cured in 2014, no complications, and she came back 5 years later and said, my gastroenterologist says I have achalasia, and they're going to fillet my esophagus with a Heller myotomy. Do you think it could have anything to do with your surgery? And asked, could redo MVD, decompressing the vagus nerve, help with my quote-unquote achalasia? Well, what is achalasia? Achalasia is a very rare esophageal motor disorder, and they have lack of esophageal peristalsis and lack of lower esophageal sphincter opening. And so food gets stuck in the esophagus, it hurts, they have chest pain, heartburn, doesn't respond to proton pump inhibitors. They often get a lot of respiratory symptoms as well. 40% of them get cough and hoarseness. And it's diagnosed by putting a special manometer down your esophagus, and you swallow, and they measure the pressure in your esophagus. So here is the upper esophageal sphincter, here's the lower esophageal sphincter over time. Here is the bolus coming down the esophagus over time. And as it gets close to the lower esophageal sphincter, there is a reflex relaxation of the lower esophageal sphincter. And guess what? The bolus of food is pushed into the stomach. That is in the normal esophagus. In patients with achalasia, defined by the Chicago classification, there is no peristalsis or ineffectual peristalsis in the esophagus. So absolutely no, you don't see that nice sequential contraction going down your esophagus. And they introduced a new concept where, yes, you have esophageal contraction, but there's no relaxation of your esophagogastric junction or lower esophageal sphincter. And so they called this new condition that they've described recently, esophagogastric junction outflow obstruction. A bit of a mouthful, sorry. Well, here is our patient's pre-op esophagram, where she clearly has peristalsis, but her lower esophageal sphincter is not opening. Normally, the pressure has to drop below 15, and in her, the pressure maintained above 21. So she can't get the food out of her esophagus into her stomach, and it's hurting her. So when you compare that, she clearly has esophageal peristalsis, so she does not have achalasia by definition. What she has probably is esophageal gastric junction outlet obstruction. Here is the classic picture of that, where you have esophageal peristalsis, but no opening of your lower esophageal sphincter, kind of like our patient. All the treatments for achalasia and esophageal gastric junction outlet obstruction, sorry for that mouthful, is destructive. They stretch the lower esophageal sphincter open, they cut it, they fillet it, they put Botox into it. And we were wondering, as she was booked for one of these, is it possible that we could correct this vagus pathophysiology without damaging the lower esophageal sphincter? And long story short, I did a redo exploration, and the lowest rootlet of the vagus nerve was caught up in a very strong scar with my Teflon, and I decompressed that, and her swallowing returned, and she's been normal for 2 years. So iatrogenic esophagogastric junction outlet obstruction caused by me can be cured by MVD. And what we're looking for is, what is the cause of all those other people who have esophagogastric junction outlet obstruction? Here's the pathophysiology that I think is going on. The vagus nerve the vagus nerve has a voluntary component to the upper. You can start your swallow voluntarily, but once it gets down, it's dorsal motor nucleus. It's a parasympathetic component of the vagus nerve that goes to the myenteric plexus, and then the myenteric plexus are in the wall of the esophagus, and then a secondary neuron goes to the esophagus to create contractions. And in the lower esophageal sphincter, you've got a balance. You've got the sympathetics closing and the parasympathetics opening. And what I believe is happening is, if you compress a vagus rootlet and lose parasympathetic innervation, you still have the ability to contract your esophagus because you've got a normal other side. You still have the ability to open your esophagus, but it's out of balance. It's got too much closure and not enough opening. And in fact, when you do those manometry tests, a part of it includes a multiple swallow, where you go swallow, 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 swallow 5 times really quickly. And when that happens, their lower esophageal sphincter does open. And what I think is happening is the normal side is producing enough to open the lower esophageal sphincter. So, esophagogastric junction outlet obstruction, not achalasia. Neurophysiologically, it's a unilateral problem. The contralateral side is normal. So esophageal peristalsis continues, ergo this is not achalasia. But the lower esophageal nerve is disrupted, just like your pupil is disrupted and it gets imbalanced with the sympathetic, with no balance from the parasympathetic. So I don't think that MVD is a treatment for achalasia, but I wonder if it may be a treatment for esophageal gastric junction outlet obstruction. And we're in that stage where we are trying to find the definitive test. Because people who can't swallow and happen to have a vessel on their MRI, on their vagus, should not be operated on. We need to tease out what would be the definitive test to say this patient, the cause of your esophageal, the lower esophageal sphincter dysfunction is from parasympathetic block of your vagus. Questions? Thank you. Questions? Dr. Sun. Dr. Sun had his hand. Yeah.
Okay.
Sorry, just one brief question. So you did you took the Teflon out and with cutting. You did mapping.
Mapping. So I didn't
without
do mapping.
anything.
No, because there was no way I was going to cut any of those rootlets.
Okay.
We have. Do you know which rootlet has parasympathetic outlet?
Sure. So anything which can figure out?
Because I do. So it's continuation of Marie's work, and it's been done by Aisha Al-Kubaisi, who is here. And the upper rootlets, the most rostral rootlets of 10, in half the patient they have a motor component, in half the patient they don't. That's why we got these high complications when you cut the upper root, the upper 1/5 or whatever was your cookbook direction of how much you should cut when you do glossopharyngeal neuralgia. Then you've got the mixed, which is motor, and the very caudal rootlet is the parasympathetic outflow. And we've done that because what we've now done on our patients is stimulated the rootlets and looked for bradycardia.
You didn't show me your portal. You didn't show us a photography of operation.
Photo. Oh yeah. Sorry. Yeah. I didn't think I would convince you with this, and but I'll just tell you, it was the lowest rootlet that was caught up with Teflon, and that the Teflon was removed.
He was first. Chris, thank you. So we generally, or at least I generally think of these syndromes as hyperactive cranial nerve disorders.
Right.
This would be against that, essentially. And I think the pupillary dilation that you showed, cranial nerve 4, 3, 4, and 6 are a little bit different. They're purely motor and so on. So what are your thoughts about this being the one instance in which it appears that not only it's not hyperactive, is quite the opposite?
Yeah, so sensory, motor, and parasympathetic. So what happens when you compress a cranial nerve that has a parasympathetic component? What happens to that parasympathetic component? I think you lose it. You don't get hyper.
It's not like an MVD hemifacial spasm.
No.
It's not inciting stimulation.
No.
You're truly just dysfunctioning, stopping the nerve.
Yes. And the question before we began is what happens when you press on a parasympathetic fiber? Do you increase it, decrease it? Well, the analogy in my world was, well, we have a neurosurgical example of compressing parasympathetic fibers, right? You lose it in the third nerve.
Any nerve you compress outside the root entry zone, we talk about losing the function. It's just a little bit of confusion about it. We've been spending all day long talking about increasing the output by root entry zone compression.
Yeah, so I don't think it's the only example.
No.
I think it's the classic example, just like the third nerve.
Any nerve.
No, I don't know that it's any nerve.
L5 nerve.
So what if you, well, that's a good argument. If you press on the parasympathetic component of 3, what happens to the parasympathetic output of 3?
Right, it goes down.
It goes down.
Right. Just like you compress L5 nerve root.
Did you have any other findings that are not directly ascribable to parasympathetic?
No. She just had, I can't open my lower esophageal sphincter. That was her only complaint. Ludwig.
Chris, first of all, thank you very much for your curiosity about this, because I think this is a really nice example of how functional neurosurgeons learn about different disciplines, and I think that's the wonderful thing in functional neurosurgery, so thank you for that. Because I know nothing about esophageal function and its treatment of its illnesses, what's the standard treatment at the moment, and how does that compare in terms of efficacy and possible complication rate to MVD?
So the standard treatment for lower esophageal dysfunction is to cut it open. So a Heller myotomy. Some people will get Botox, which loosens it for 3 months, but then they get scarring. But the standard treatment is to fillet it open, and then you get like food falling in and acid coming up.
So it's far from ideal, essentially.
You destroy the lower esophageal sphincter. So this is the beginning. I don't know what achalasia is, but we're reaching out to gastroenterologists who are scratching their head and saying no way. And so we'll see if we can convince them.
What happened to your patients in whom you did vagal nerve block for Vancouver syndrome? Did they get achalasia?
I didn't ask them. Yeah, I didn't ask them, and they're post-op NPO, in the OR, in the recovery room. We never got them to swallow anything at that. We weren't thinking along those lines.
Because that could be an easy way to demonstrate that at least the pathophysiology makes sense. Because I have one case where the patient had glossopharyngeal neuralgia. She was gamma knifed, and the glossopharyngeal neuralgia completely disappeared. But then she remained with HELPS. So then I did an MVD for cranial nerve 10, but the artery was going through the lowest rootlet and the one above. So I had to cut one to just transpose it somewhere else, because otherwise it was just compressing everything. So I cut the lower rootlet, and this patient was concealed pre-op with ENT, and we had a plan of, fillers for vocal cord and so on. And he did not develop achalasia or any, esophageal problem after, the last rootlet was cut. So it's an interesting thought, but it could be probably easy to prove just by doing a manometry after your block.
Yeah, well, you were brave to cut the lowest rootlet of the vagus. Yeah, I would not have done that.
Yeah.
But you got away with it. Professor Kraus.
I-
Oh, sorry.
Yes.
Yes.
So I remember that you demonstrate maybe that patient video
Yeah, I'll
long
get it
time
for you.
ago.
Yeah.
So at that time it was very impressive. So as far as I remember, you put the Teflon piece between lower fiber, maybe number 4, something like that. Number 4 of vagal lobe, and between artery and vagal lobe.
Yeah, so for HELPS, the compression is typically pica, either coming from in front, looping
Yes,
backwards, in which case that's easy.
Yeah.
You can just push them forward.
Yeah, okay.
Or coming from below, also easy. Sometimes they come through between the roots. And the other thing you have to be careful of is, do you know the cranial 11, which is really a misnomer? It's just another vagus rootlet.
Yeah.
You can't push the vessel down into that you'll get vocal cord problems too. So, and also the manipulation of vagus, it's so much more sensitive than 7, which is so much more sensitive than 5. You really can't push it around.
Yes, what I want to ask is the maybe during the reoperation, maybe the removal of the Teflon piece,
Yeah.
and then transposition of the causative vessel. And then in that case, you don't need to cut.
Yes. So I think the same problems are going to happen if this ever took off as with trigeminal neuralgia. I had too much Teflon in there. I was just stuffing the artery around, and some of that Teflon came up and really scarred in. It was 5 years later, and I think it hurt the lowest rootlet of 10.
Actually, I have a experience with, of course, that is not many. However, the over 80 patient with cross-pharyngeal neuralgia, most of them were treated with a transposition. If some patient with the perforating branches directly from the offending vessels, in that case, I have to do the interposition. Otherwise, I always transposed. In those patients, that kind of problem wasn't developed. So I was very curious that you put something Teflon between them. So after follow-up, I didn't expect this kind of presentation. However, it is very, I am very grateful for you to see what happened after your decompression surgery in very rare cases. Thank you very much.
Pleasure.
Yeah,
You're
Chris,
welcome.
that's great to see how you could possibly expand the concept of MVD. And there are hundreds of patients out there with vagal nerve stimulation for epilepsy, depression, and so on.
And what's the side effect of vagal nerve stimulation?
Yeah,
Cough.
yeah, cough also. But but would you think that some of these patients then would have a, I don't know, negative or positive effect on gastric opening, or?
Yeah, I don't yet know enough the relationship of where you put the vagal nerve stimulator to where the parasympathetics come off the vagus. They might come off, I don't know.
Yeah, but perhaps it would be worthwhile to look into it.
I don't think vagal nerve stimulators complain of dysphagia, but they often complain of cough. Moji?
So about, I'm going to say well over 10 years ago, I put in a vagal nerve stimulator for a patient with intractable hiccups, and it's still working. I wonder, actually, in follow-up to Joachim's question, whether this could be something that can potentially be studied in patients that do undergo vagal nerve stimulation to see whether there's specific settings that might accelerate the parasympathetic drive of the vagal nerve compared with other functions. And yes, indeed, cough is a side effect, but nonetheless, with stimulation, potentially we can change the balance and
Sure.
and have a better understanding of what the actual contribution of the vagal nerve is. I mean, the interest, well, the rest is philosophy, so I'll leave it for later.
Yeah, well, it's interesting, and it's fun to make new collaborations with the gastroenterologists. We're going to take maybe just a 10-minute break to stretch your legs because the online people are expecting to come at 4.